Imagine a lush green pasture, seemingly idyllic. Or maybe a barn. Looks clean, well-maintained.
Uh-huh.
Yet lurking in these familiar scenes can be this invisible threat, one that can swiftly, devastatingly impact an animal like a horse.
Absolutely.
We're talking about common chemicals often used for good reasons that can turn into potent poisons when things will go wrong.
Yeah, it's a real risk.
Today, we're diving deep into organophosphate, or OP, and carbamate poisoning in horses.
Okay.
Our aim is to kind of cut through the complexity, get you quickly well-informed on this critical veterinary topic, pulling the key insights from the sources you shared.
It's definitely a crucial topic. And while these compounds are, look, they're widespread tools. Agriculture, pest control, even vet med uses them.
Right.
But their potent nature means understanding the risks is absolutely paramount for anyone connected to horses or really any agricultural environment.
Knowing the danger is the first step.
Exactly. First step to preventing it.
So let's start with the hidden danger itself. What exactly are organophosphates and carbamates? These aren't just, obscure poisons.
No, not at all. They're pervasive.
You find them as active ingredients in everything from farm sprays to, household bug killers, and even in veterinary stuff, right? Insecticides, dewormers.
That's right. Insecticides, anthelmintics, yes. What's really important to grasp is despite all these uses, they are potent neurotoxins.
Neurotoxins, okay.
Which means they can cause severe poisoning. Usually it's accidental exposure or misuse.
Misuse, like wrong dose or something.
Yeah, or using a product not intended for that species or situation. And a really vital nuance here. Not all pesticides labeled carbamates actually inhibit acetylcholinesterase.
Oh, interesting. So the label might be confusing.
It can be. The mechanism we're about to talk about isn't universal even within that category. And remember, there are dozens of different compounds, hundreds of formulations.
Wow.
So the toxicity levels can vary hugely between them.
Okay, let's unpack this. We've said neurotoxins, but how do they actually wreck things? What's the core mechanism?
Right. So it all comes down to an enzyme called acetylcholinesterase. Let's call it AC.
AC. Got it.
Its normal job is crucial. It breaks down a powerful chemical messenger, acetylcholine, or SE. ADC is basically the go signal for nerves and muscles.
Okay, the go signal.
Now, when OPs and carbamates get into the body, they disable this AC cleanup crew.
They stop the cleanup.
Exactly. Which means acetylcholine, the go signal, just builds up in the communication gaps between nerves, the synaptic clefts.
So it's like the signal is stuck on.
Precisely. Imagine a constant flood of go signals with no way to turn them off. Non-stop stimulation.
And this is where it gets really critical, right? For vets trying to figure things out, both OPs and carbamates jam that off switch, but how they do it is different.
That's the key distinction, yes. And it hugely impacts the clinical picture and treatment.
So what's the takeaway here for someone facing this?
And think of it like this. Organophosphates, the OPs, are like supergluing that off switch. They bind through phosphorylation.
Okay, phosphorylation.
And it is essentially permanently inactivates the enzyme, or at least makes it incredibly slow to recover.
Permanently? What?
Functionally, yeah. The body has to actually build new enzyme molecules, new switches. And that takes time, which means much longer, often more severe clinical signs.
Longer signs, that makes sense.
And there's this concept called aging. After maybe 24 to 48 hours, that bond between the OP and the enzyme gets even stronger, like the glue sets harder.
Making it even harder to reverse.
Exactly. So with OPs, time is absolutely everything. Getting treatment started fast is critical.
Okay, OPs, permanent, aging effect, long duration. What about carbamates?
Carbamates are different. They bind through carbamylation.
Carbamylation.
And this bond is reversible. It's less stable. The carbamate can spontaneously detach, pop off, allowing the ACE activity to regenerate.
So the enzyme can start working again on its own.
Yes, eventually. This typically means shorter clinical signs compared to OPs, but this reversibility can also mess with diagnostic tests.
How so?
If you take a blood sample and don't process it quickly, the carbamate might detach in the tube, and the enzyme activity looks normal or less inhibited than it really is in the horse.
False negatives, got it.
Right. So rapid sample handling is key for carbamate suspicion, but the overall effect for both is this constant on signal, causing widespread overstimulation.
Affecting.
Nervous system, muscles, breathing, the gut. Pretty much everything controlled by acetylcholine.
With this stuff potentially everywhere,
Yeah.
how does a horse actually encounter it? How do they get poisoned?
Well, the most common way is definitely eating it, oral ingestion.
Like in their feed?
Exactly. Grazing pastures sprayed with pesticides, eating contaminated hay or feed, even pesticide drift from a neighboring field landing on their grazing area.
Drift, okay.
We also see accidental ingestion. Horses are curious. They might chew on a discarded pesticide container left lying around, or maybe wood treated with certain preservatives.
Oh, wow, yeah.
And sometimes, unfortunately, it's improper application of veterinary products.
Like giving too much dewormer.
Exactly. Overdosing or using a product incorrectly, maybe a cattle product on a horse, that kind of thing. Topical parasiticides, too, if misused.
And environmental contamination.
Yeah, like runoff from treated fields getting into ponds or streams where horses drink.
Okay, so mainly eating it. Is it common?
Well, these poisonings aren't as frequent in horses as, say, in cattle or small animals, but they definitely happen. Most cases tend to pop up in spring and summer.
Makes sense when pesticide use is highest.
Right. And here's a really crucial point, something that often surprises people. These pesticides can stick around in baled hay for a long time.
How long?
Up to 6 months.
6 months in hay.
Yes. So hay, bought much later, could still pose a risk if it was contaminated initially. Oral ingestion is definitely number one for horses.
And you mentioned risk factors. Something about body fat.
Yeah, some of these compounds are lipophilic. They dissolve in fat, so they can get stored in body fat and then slowly released. In animals with less body fat, a leaner horse, the toxin might be more concentrated in their active tissues, potentially leading to more severe signs.
Interesting. Okay, so once this overstimulation kicks in, the signs, what does it actually look like? You said rapid onset.
Often very rapid, yes. Minutes to hours, sometimes maybe stretching to days, depending on the specific chemical, the dose, how they got it.
Right.
But once signs start, they often progress quickly. It's not usually subtle for long.
And clinically, vets have a term for this collection of signs.
Yes, we call it the cholinergic toxidrome. It's that characteristic mix of muscarinic, nicotinic, and central nervous system effects all hitting at once.
Okay, cholinergic toxidrome. Let's break that down. Muscarinic signs first.
Right. Muscarinic effects are things like excessive drooling, hypersalivation, really profuse.
It's pouring out.
Yeah, sometimes. And excessive tearing, lacrimation. Pupils might become very small, pinpoint that's meiosis. Then there's the gut. Profuse, watery diarrhea, sometimes even bloody, frequent urination, and colic abdominal pain is very common.
Colic, right. Big one in horses.
Huge. And something quite distinctive in horses is sweating. Profuse sweating, maybe patchy all over or generalized.
Sweating a lot. That's different from dogs or cats.
Right, very different. Much more prominent in horses. You might see a slow heart rate, bradycardia, but honestly, in horses, sometimes the stress response kicks in, and you might even see a fast heart rate initially.
Okay.
And then the breathing. Bronchoconstriction, the airways tighten up, and bronchorrhea, excess fluid in the airways.
Making it hard to breathe.
Very hard. Dyspnea, you might hear wet lung sounds. So yeah, picturing it, it's like the horse's body systems are just overflowing, sweating, drooling, diarrhea, can't breathe well.
That sounds absolutely awful. It's a complete overdrive.
It is, stuck on full throttle. And that sweating is really a hallmark we look for in horses. Interestingly, though, in horses, sometimes those GI signs, the colic, the diarrhea, are the main thing you see. The nervous signs might be minimal or even absent altogether.
Really? Even though it's a neurotoxin?
Yes, it's a bit of a species variation. The underlying mechanism is the same, but the outward signs can be weighted differently in horses.
Fascinating. Okay, what about the nicotinic signs?
Nicotinic effects relate more to the muscles. You see muscle fasciculations, visible twitching.
Like little ripples under the skin?
Exactly. Often noticeable around the face, neck, shoulders first, then generalized muscle tremors, weakness, stumbling, incoordination, ataxia.
Ataxia.
And in severe cases, the horse might go down, become recumbent, and develop paralysis. Critically, paralysis of the respiratory muscles.
Which means they can't breathe.
Correct. That's often the ultimate cause of death.
And finally, the central nervous system signs.
CNS. CNS signs can range from anxiety, apprehension, restlessness, sort of jumpy and worried, to depression, lethargy, more incoordination. Seizures aren't super common, but they can happen.
Seizures too. Wow.
Yeah. And it can progress to coma. And again, respiratory arrest due to effects on the brain's respiratory center.
And you mentioned in really bad cases, massive poisoning.
Yeah, acute, massive exposure. The horse might just rapidly develop severe trouble breathing, collapse, and die from respiratory failure very quickly before you even see the full range of other signs develop.
Just catastrophic.
It can be, yes.
So with all these potential signs, some overlapping with other problems, how do vets actually pin this down? How do they confirm it's OP or carbamate poisoning? It sounds like detective work.
It really is piecing together clues. Two things are absolutely critical right up front.
Okay.
First, the history of exposure. The vet needs to ask pointed questions. Was any pesticide used recently? On this farm? On the neighbor's property? Is there any chance of spilled chemicals, open containers?
Sounding intelligent.
Exactly. Second, the clinical signs themselves. That specific constellation we talked about, the muscarinic, nicotinic, CNS stuff, especially if you see that combination of massive sweating, drooling, colic, and muscle twitching all together, that's highly suggestive.
That combo really points towards it.
It strongly points towards it, yes.
Now, you mentioned something earlier, a therapeutic diagnosis.
Yeah.
Using atropine. That sounds interesting. How does that work?
Ah, yes, the atropine test dose. It's quite a clever diagnostic aid.
So what do you do?
You give a small, standard pre-anesthetic dose of atropine sulfate intravenously, say 0.02 to 0.04 milligrams per kilogram.
Okay, small dose.
In a normal, healthy horse, that dose would cause mild effects like a slightly faster heart rate, maybe the pupils dilate a little, normal anticholinergic signs.
Right.
But in a horse poisoned with an OP or carbamate, their receptors are already flooded with acetylcholine. So that small dose of atropine does basically nothing.
It doesn't work.
Not at that dose. You'd need a much, much higher dose, often 10 times higher, like 0.2 to 0.4 milligrams per kilogram, just to start seeing those same mild anticholinergic effects like pupil dilation or dry mouth.
Because the acetylcholine is outcompeting the low dose of atropine.
Precisely. The receptors are already overwhelmed. So if the horse doesn't respond to the low dose, it strongly supports OP carbamate poisoning. It helps rule out other things like, say, pyrethroid toxicity, which wouldn't block the atropine response like that.
That's really neat. A diagnostic test using a treatment drug.
It is. Very useful in the field. Then, of course, we have lab tests. Cholinesterase activity measurement is key.
Measuring that AT enzyme we talked about.
Exactly. In a live horse, we measure AC activity in whole blood, or specifically in the red blood cells.
And what level is significant?
Generally, if the activity is inhibited by more than 50% compared to normal baseline levels, that's significant. If it's down by over 70%, that usually correlates with obvious, overt clinical signs. The horse is clearly sick.
Okay. And if the horse has already died?
Then measuring ACE activity in the brain is the most reliable test. Brain HC degrades less after death compared to blood.
But there was that catch with carbamates.
Right. Because carbamate inhibition is reversible, you have to handle those samples correctly and quickly. Freeze them immediately, get them to the lab fast. Otherwise, the enzyme activity might recover in the test tube, giving you a false negative. Timing is critical.
Got it. What else? Toxicology screening.
Yes, definitely. We can analyze stomach contents, colon contents, maybe suspect feed or water samples, trying to find the specific chemical compound itself.
Find the smoking gun.
Basically. In deceased animals, we can also test tissues like liver, kidney, fat, or urine. This helps confirm the diagnosis and identifies the exact agent, which can sometimes inform prognosis or trace the source.
Are there other things that look like this?
Oh, yes. Severe bacterial or viral gut infections, certain other toxicities. Differential diagnoses are important. And another point, post-mortem exams often don't show specific damage.
No obvious changes to the organs.
Not specific ones caused directly by the OP carbamate mechanism. You might find leftover insecticide granules in the stomach, or maybe notice a strong chemical smell. But the tissues themselves often look frustratingly normal on initial inspection. So history, signs, and specific testing are really crucial.
Okay, so diagnosis is made. Now, treatment. You said it's an emergency.
Absolute emergency. Every minute counts. Treatment focuses on three main things: decontamination, specific antidotes, and aggressive supportive care. It's a real race against time.
Decontamination first. How do you do that?
Depends on how they were exposed. If it was dermal, they got it on their skin, maybe rolled in it.
Yeah.
Immediate, thorough washing. Use soap or detergent and lots of lukewarm water. And critically, the people doing the washing must wear protective gear.
Yeah.
Gloves, apron, maybe eye protection.
Because they could get exposed too.
Absolutely. These things can be absorbed through skin. Avoid harsh scrubbing, though. That can actually increase absorption. Just gentle but thorough washing.
Okay. And if they ate it? Oral ingestion.
For very recent ingestions, maybe within an hour or two, gastric lavage, stomach pumping might be considered. But more commonly, we give activated charcoal.
Charcoal, like for grilling.
Huh? No, not quite. It's a specific medical-grade charcoal. It comes as a powder. You mix it into a water slurry.
Okay.
The dose is about 1 to 2 grams per kilogram of body weight, sometimes up to 5 kilograms, given via a nasogastric tube down the nose into the stomach.
And what does it do?
It acts like a sponge. It absorbs the toxin that's still in the gut, binds it up so the horse can't absorb it into their bloodstream.
Prevents further poisoning?
Exactly. Then, often after the charcoal, we give a saline cathartic like magnesium or sodium sulfate, basically a laxative or maybe mineral oil.
To speed things up.
Yep, to speed up the passage of the charcoal toxin complex through the gut and out the other end. But use caution with cathartics if the horse is already severely dehydrated.
Right, don't want to make dehydration worse. Okay, decontamination done. Now, the antidotes, you mentioned atropine before for diagnosis.
Yes, and it's also the main antidote for the muscarinic signs.
Just the muscarinic ones.
Primarily, yes. It's great for counteracting that excessive drooling, tearing, gut hypermotility, the colic pain associated with that, and especially the life-threatening bronchoconstriction and airway secretions.
So it helps them breathe better.
Critically important for breathing, yes. But, and this is crucial, it does not reverse the nicotinic effects.
Meaning the muscle twitching and paralysis.
Correct. Atropine won't stop the muscle fasciculations or, more importantly, the respiratory muscle paralysis.
So it's not a complete fix on its own.
Not at all. It manages some of the most distressing and dangerous muscarinic signs. Dosage-wise, the initial treatment dose is higher than the test dose, usually 0.1 to 0.2 milligrams per kilogram.
How's it given?
Typically give about a quarter to half of that dose intravenously for rapid effect, and the rest intramuscularly or subcutaneously for a more sustained effect.
And then keep giving it.
Yes, you titrate it, give repeated doses, maybe every 10 to 15 minutes based on the horse's response. You're aiming to control the respiratory distress and the hypersalivation.
What tells you you've given enough? Or too much?
Signs of adequate atropinization are things like dilated pupils, dry mouth and nose, and easier normal breathing. But you have to be careful not to over-atropinize.
What happens then?
Too much atropine can cause ileus. It paralyzes the gut, which leads to severe colic, potentially worse than the original poisoning colic. It can also cause CNS excitement. There is a suggested maximum total dose for horses, around 65 milligrams total, because of that ileus risk.
So it's a balancing act.
Very much so. Sometimes, if atropine is causing gut issues, a drug called butyrylscopolamine might be used specifically for colic control instead.
Okay. Atropine for muscarinic signs. What's the other antidote? 2-PM.
Prelidoxin chloride, yes, or 2-PMM. And this one raises that important question. Why is it mainly for OPs?
Right. You said it wasn't really for carbamates. Why?
Because 2-PM is what we call a cholinesterase reactivator. Its job is to break that strong bond between the organophosphate and the ACE enzyme.
The superglue bond.
Exactly. It pries the OP off, reactivating the enzyme so it can start breaking down acetylcholine again.
So it fixes the underlying enzyme problem for OPs.
Correct. It's not needed for carbonates because that bond breaks on its own. Eventually, it's already reversible.
Makes sense. How is 2-PM given?
Dosage is typically 4 to 6 milligrams per kilogram, given slowly intravenously. Some sources say 20-35 milligrams per kilogram slow IV. And crucially, it's most effective early on.
Within that aging window.
Precisely. Best within the first 24 to 48 hours of OP exposure before that enzyme toxin complex ages and becomes truly irreversible after that 2-PM doesn't work nearly as well or at all.
So again, time is critical. Okay, decontamination, atropine, 2-PM for OPs. What else? Supportive care.
Absolutely vital. You can give all the antidotes you want, but if you don't support the horse's basic body systems, they won't make it.
Like what?
Respiratory support is huge, making sure they have a clear airway. Supplemental oxygen is often needed. In severe cases with respiratory paralysis, mechanical ventilation, basically a ventilator, might be required.
Wow, intensive care.
Very much so. We might also use diuretics like furosemide to help clear fluid from the lungs if there's pulmonary edema, and bronchodilators like albuterol to help open the airways.
And fluids.
Intravenous fluid therapy, yes. Critical for maintaining hydration, supporting blood pressure and circulation, and helping the kidneys flush out any absorbed toxins or metabolic byproducts.
What about seizures or the anxiety?
Good point. We need to control seizures or severe agitation. Diazepam or Valium is often used, or midazolam, sometimes phenobarbital for longer-lasting seizure control.
Okay.
But here's a really important do not USE. Avoid phenothiazine tranquilizers. The most common one is acepromazine, or ACE,
Why not acpromazine? It's used commonly in horses.
because it can significantly lower the seizure threshold. In a horse already at risk of seizures from the toxin, giving acepromazine could actually trigger them or make them worse.
Yeah.
Very dangerous here.
Good to know. What about for colic pain, if atropine isn't enough or causes ileus?
Other pain relief can be used carefully. Drugs like xylazine or butorphanol are generally considered safer options for managing colic pain in this specific situation.
And just general nursing.
Essential. Keep them warm, prevent hypothermia. If they're down, recumbent, provide padding. Turn them regularly to prevent pressure sores. Monitor their vital signs, heart rate, breathing, temperature very closely. It's intensive nursing care.
It sounds incredibly intense. So after all that, what's the outlook? The prognosis?
Honestly, it's generally guarded to fair.
Guarded to fair. So not great, but not hopeless.
That's a good way to put it. It's a very serious situation. Outcome is definitely not guaranteed. It really depends heavily on several factors.
Right.
What specific toxin was it? How much did they get? How were they exposed? Eating it is often worse than skin contact. How fast did treatment start? That's a huge one.
Right, the time factor again.
Absolutely. And how severe were they when they first presented? A horse that comes in already struggling to breathe or having seizures has a much worse, often grave prognosis, and complications that develop during treatment also affect the outcome.
So let's say they survive the initial crisis. Is it smooth sailing after that? What about long-term recovery? Are there lingering effects?
Unfortunately, yes, there can be. It's not always just a quick bounce back.
Like what?
Some horses, particularly after exposure to certain OPs, can develop what's called delayed neurotoxicity or sometimes an intermediate syndrome.
Delayed, how long after?
This can show up days, even weeks after the initial poisoning seems to have resolved. It often involves muscle weakness, especially affecting the respiratory muscles, but also potentially limb muscles.
Weeks later, wow. So the off switch is still kind of glitchy.
That's a decent analogy, yeah. The acute crisis is over, but the neuromuscular function isn't fully normal yet. Long-term cognitive deficits have also been reported, though maybe harder to quantify in horses.
And you mentioned something specific in foals.
Yes, there have been reports of bilateral laryngeal paralysis, basically. Paralysis of the flapper cartilages in the throat occurring in foals after they were given an OP anthelmintic, a dewormer, affects their breathing and airway.
So recovery isn't always complete,
Mm.
which really brings us back to
Prevention, absolutely paramount. Given the severity, the difficulty of treatment, and the potential for long-term issues, preventing exposure in the first place is by far the best strategy.
So what does that involve practically?
Careful handling and storage of all pesticides. Keep them locked up, secured, away from where animals can possibly access them. Read the labels.
The label is key.
Always. Use the product only as directed for the intended species at the correct dose. Dispose of empty containers properly. Don't leave them lying around. Think about pasture management. Be aware of spraying schedules on your property and neighboring properties to avoid drift onto grazing areas.
And the hay issue.
Verify your feed sources. If you're buying hay, especially locally, it doesn't hurt to ask the supplier about their pesticide use or practices. Just being aware and asking questions.
Diligence, basically.
At the end of the day, yes. Diligence and awareness.
Okay, so to quickly recap our deep dive, we've really unpacked how these organophosphates and carbamate work, jamming that crucial A-key enzyme, causing nerve overstimulation.
Right, the core mechanism.
We walk through those distinct signs.
Yeah.
The muscarinic ones like drooling, sweating, colic, the nicotinic muscle twitching and weakness, and the CNS effects, noting how horses often show really prominent GI signs and sweating.
The cholinergic toxidrome, yeah, with that equine emphasis.
We covered the detective work for diagnosis history, signs, that clever atropine test dose, and the lab test for AEK activity.
Piecing it all together.
And then the emergency treatment. Critical decontamination, the life-saving antidotes like atropine for muscarinic signs, and 2PM specifically for OPs, plus that all-important supportive care.
The whole package needed for a chance at recovery.
Which, as you said, has a guarded prognosis and potential long-term effects.
Making prevention absolutely vital.
So that leaves us, and you the listener, with a final thought to chew on.
Given how invisible these compounds can be, and their potential to contaminate something as common as hay for months, what steps can you take, starting now, to better ensure the safety of the horses or other animals in your care, or even just in your community? How might knowing this change your everyday awareness, maybe make you look a little closer at environmental safety around these amazing animals we all care about?